A very good morning to all of you. This is a mandatory slide from the AIOS side, so it's the second slide. As with all diseases, the management of squint starts with a history, whether it's, what are the presenting complaints, it's asthenopia, diplopia or a squint. Age of onset, early onset, long duration of squint and constant angle points towards a poor prognosis. At times you may need to go and look back the old photographs to find out the duration of the squint. Pattern of deviation, whether it is constant or intermittent, same or alternating. Precipitating factors like fever or trauma, developmental history of a child, and treatment history in the form of refraction, glasses, occlusion, or a surgery. We divide assessment into two parts, assessment of sensory system and assessment of motor system. Assessment of sensory system would include a visual acuity assessment, fixation, binocularity and stereopsis, and there could be various sensory anomalies in these patients, which could be amblyopia, suppression, low stereopsis, eccentric fixation on an ARC. For testing visual acuity of adults, we have Snellen's chart. For children, we have got various types of children's chart, which could be Allen's or a Cardiff chart, or a preferential looking chart in the form of a Teller's acuity chart. A simple maneuver of occluding the apparently fixing eye would help us find out the vision in the other eye. So it's a case of a small child where we try and occlude the right eye and child resents it. This indicates a poor vision in the left eye, needs further evaluation and possibly an amblyopia therapy. Use the correct method, do not go in for incorrect methods. Try and use penalization whenever they are indicated. Do not use them in all cases. Fixation can be tested with the help of direct ophthalmoscope. Central fixation indicates good prognosis for amblyopia therapy, while eccentric would point towards a poor candidate for an amblyopia therapy and chances of regression of squint. Assess binocularity with the help of a Wirth 4-dot test, which is easily available with us. Grade the binocularity with the help. We can also use Begonley's glasses to assess the binocularity. A gross stereopsis can be tested with the help of Lang's 2-pencil test. Try and avoid end-on view of the pencil or the pen. Grade the stereopsis with the help of TNO Titmus or a Randot. For distance, you can use Frisbee-Davis or a distance Randot test. Now we move on to assessment of motor system. It starts with looking at the head posture, detect the squint, assess and control the accommodation, measure the angle of deviation, and look for the ocular rotations. Head posture could be a tilt, turn, or a chin up or down. There could be various causes. Even a trichytic lash can cause a head posture. This is a case of 8-year-old girl child whose complaints of head posture has been broadly ignored by the parents as mischief. We look at the old photographs. She constantly maintains a head posture towards right or eyes towards the left. On examination, she has a nystagmus with null and levoversion. Looks can be deceptive. You can have a pseudo-esotropia, pseudo-exotropia, or a pseudo-hypertropia. So it's important to rule out pseudo-strabismus. Detect the squint. Always use accommodative targets. You can use toys and mobiles when you're examining children. A 6-month-old child showing accommodative esotropia on an accommodative target. All that he needs probably is a pair of glasses. Light reflexes, Bruckner's reflex can help you find out the squinting eye. Hirschberg would help us assess the degrees of strabismus. Do a cover test to pick up the squint. So this is cover test is being done where where we cover the apparently fixing eye and look for the movement of the non-fixing eye. Do a cover and cover test. Here in this case, we cover the eye and look for the movement under the cover. We try and disrupt the fusion and look for the movement of the eye after the cover is being removed. Alternate cover test, which gives you a combination of tropias and phorias. You may need a special occluder called as Spielman's occluder for the unmasking of DVD. You can see here. For assessment of deviation, ask the child to fixate at a 6-9 or 1 line less than the best corrected visual acuity. For near, you should always use an accommodated target. Do not use a torch to assess the deviation. Distance acuity charts are easily available, but the problem of these charts is the height. You can miscalculate the squint when there is A or V pattern, so always use a chart which is at the eye level. Control the accommodation. It is very important to relax the accommodation because we don't know how much a child is accommodating and how much is the dynamic component of the squint. Children can accommodate better than adults, so do not hesitate to use atropine or hometropy in children. Use proper refractive glasses, a case of partially accommodative esotropia, where most of the squint a case of partially accommodative esotropia where most of the squint is corrected with the help of glasses. Note the difference between the primary and secondary deviation. We can clearly see there's much in a larger secondary deviation as compared to the primary deviation in cases of already operated or incompetence strabismus. Measure the squint in up on the down gazes, 25 degrees up and 35 degrees down. Look for AV pattern. Look for the variation in distance and near. If there is a variation in distance and near, look for convergence excess, high AC by ratio, convergence insufficiency, or a divergence excess, which can be true or pseudo. For accurate measurements, use prism bars or a synaptophore. Test for ocular rotations, as limitation of movement can be because of restriction or underaction, for which do not hesitate to do a force reduction test or an active force generation test. Do not miss the oblique overactions. This is a case of exotropia with inferior oblique overactions both eyes. Another case of esotropia with both eyes superior oblique overaction. For incompetent squints, there could be different set of complaints like diplopia, abnormal eye movements, restriction of gazes, anomalous head posture. They all would need detailed evaluation and a case-to-case based management. Single most important requirement to assess a squint, a very complex machine, very seldom used, is human brain. Thank you.